Thank you, Professor Hamza. Actually, you started my lecture by asking the question for which patient revascularization is indicated. Thank you for that. And congratulations, Professor Magdi Abdhamid and all the members of the Egyptian Society of Cardiology. Really, it's an amazing amazing course or workshop. All what's new in 2019 will be presented in only 2 days. My talk about this is yes. I think when to revascularize in chronic coronary syndromes, this is the holy grail of the ischemic heart disease in chronic coronary syndromes. And 1 year back, the European Society of Cardiology, not in their last guidelines, but actually starting to use the term of chronic coronary syndromes 1 year back, the new name for what has been known as a stable coronary artery disease, one that brings the nomenclature more in line with contemporary understanding of its development, progression, and management. Chronic coronary syndromes recognize coronary artery disease as a dynamic process, not stable, of atherosclerosis and altered arterial function that can be modified by lifestyle changes, pharmacological therapies, especially those medications that can prevent or has a secondary prevention ability, like statins, antiplatelets, other antithrombotics, and ACE. Revascularization also is a cornerstone when it is appropriately indicated and implemented. All of these will result in disease stabilization and even regression. This diagram represents the natural history of the chronic coronary syndromes, and the prognosis is a spectrum between the highest risk and the lowest risk. The lowest risk, in which the lifestyle changes are properly implemented with appropriate control of risk factors and the prescriptions of pharmacological treatment, and only the prognosis has been altered when appropriate revascularization is indicated in special subset of patients which will gain benefit of this strategy. Here is the guidelines. I will not repeat what my friend and colleague Dr. Hussam said in his very impressive lecture before me. You know all these 6 syndromes that newly introduced in the most recent guidelines. If we will come to the first 2 syndromes, patients with stable angina symptoms and or dyspnea and patients with LV dysfunction, those are my main core to describe when revascularization is indicated in these 2 syndromes. For the third one and fourth one, in which asymptomatic or symptomatic patients with stabilized symptoms either before 1 year or after 1 year, those patients actually need periodic assessment for risk scores, assurance of the compliance of the patients, and also identification of any new comorbidities that could happen and interfere with the disease progression. For the 5th syndrome with vasospastic or microvascular disease, of course, and apparently here revascularization is futile and not indicated. And the last one is the most perplexing or confusing one, or we can say that there is a lack of evidence for those patients, asymptomatic subjects in whom coronary artery disease is detected as screening, maybe by chance, preoperatively, for example. There is no consensus at all up till now that there is a proper management of those patients, either medically or even with revascularization. So our talk will concentrate on the type 1 or syndrome 1 and syndrome 2 of chronic coronary syndromes. In those 2 subsets of patients, the rationale for revascularization and the indications for revascularization in patients with chronic coronary syndromes who receive guideline recommended medical treatment are the persistence of symptoms despite medical treatment and or the improvement of prognosis. Several studies have shown that myocardial revascularization, either by PCI or CABG, more effectively relieves angina, reduces use of anti-anginal drugs, and improves exercise capacity and quality of life compared with a strategy of medical therapy alone during short and long-term follow-up. Here, revascularization has an edge of improving the symptoms. While it is generally, on the other hand, while it is generally accepted that coronary revascularization reduces the risk of death and myocardial infarction compared with initial medical treatment among patients with acute coronary syndromes, the prognostic benefit is less well established among patients with stable coronary artery disease, or recently described as chronic coronary syndromes. And even the symptomatic benefit of revascularization just from 2 years has been vigorously challenged by what's called Orbita trial, which for the first time, using what's called sham procedure or placebo-controlled randomized trial of PCI in stable angina in a significantly hemodynamically significant lesions, both angiographically, as the lesion is more than 80% stenosis, or physiologically, as indicated by FFR mean of 0.69 and IFR of mean of 0.76. PCI, although was safe and physiologically effective, and significantly reduced the ischemic burden as assessed by stress echo. And however, in this single vessel and geographically guided trial, there was no difference in exercise time increment between PCI and placebo. Orbita raises the issue of whether symptom relief of PCI in the specific setting of stable single vessel coronary artery disease may be related, at least in part, to a placebo effect. However, the limitations of this trial, it is a short observational trial with a small sample size, including patients with mild symptoms, around 25% of patients, and there is group imbalance in ostial and proximal lesions being more in the arm of the PCI, with loss of follow-up after randomization and insufficient power to detect a true difference. Nevertheless, the Orbita study underlines the value of optimal medical therapy in the management of stable coronary artery disease. In this very interesting recent poll carried on by the American College of Cardiology and asking many interventional cardiologists, expert interventional cardiologists, since the Orbita trial, what change in the PCI volume have you seen in stable coronary artery disease? And the answer is around 90% of them, no change. And the Orbita trial has generated many heated debates, particularly on social media, but the results of this poll suggest that the trial's results have had little clinical impact. On the other hand, among patients with multi-vessel disease, the assessment of frequency of angina and the quality of life measures in the Syntax, Freedom, Excel trials consistently showed early and sustained improvement for both BCI and CABG during long-term follow-up. And also in this very important meta-analysis by Stephen Wendiker for assessment of revascularization versus medical treatment in patients with a stable coronary artery disease, including 100 trials in more than 90,000 patients with more than 260,000 patient years of follow-up were included in this meta-analysis, and CABG especially was associated with a survival benefit compared with medical treatment. And also new generation drug-eluting stents were associated with improved survival compared with medical treatment with less incidence of spontaneous MIs. Data reported in 2018 indicate a potentially broader prognostic impact of revascularization strategies. And this came after the 5-year follow-up of the FAME2 trial, which confirmed a sustained clinical benefit in patients treated with PCI, specifically target the ischemia-producing stenosis plus optimal medical treatment versus optimal medical treatment alone, in terms of a significantly lower rate of urgent revascularization and a lower rate of spontaneous MI. Again, a very recent meta-analysis at the beginning of this year by Zimmerman et al., including 2,400 patients, all of whom underwent invasive physiological guidance, showing a significant reduction in cardiac death and MI after a median follow-up of 33 months with FFR-guided PCI versus medical therapy. Together, these new data support a less restrictive indication for revascularization in chronic coronary syndromes. In addition to specific anatomy like left main or significant ischemia more than 10%, when PCI is restricted to angiographic stenosis on large vessels, causing a significant intracoronary pressure gradient as assessed by FFR or IFR, carries a very important prognostic benefit. Here are the indications for revascularizations in patients with stable angina or silent ischemia. They are classified for prognostic purpose or symptomatic purpose. For symptoms, it is indicated when there is a hemodynamically significant coronary stenosis in the presence of limiting angina or angina equivalent like dyspnea, with insufficient response to optimized medical treatment. For prognosis, there are 5 main indications. First, left main disease, more than 50%, proximal LAD stenosis more than 50%, 2 or 3 vessel disease with stenosis more than 50%, with impaired LAD function with an ejection fraction less than 35%. Large area of ischemia detected by functional testing, more than 10% of jeopardized left ventricle, and even this statement has been also challenged by the recent ischemia trial, or abnormal invasive FFR. And the last one is a single remaining patent coronary artery with significant stenosis more than 50%. Here is the diagram, decision tree for patients undergoing invasive coronary angiography in patients with chronic stable chronic ischemic syndromes, in which we have, in addition to typical anginal symptoms, we have to document ischemia, either non-invasively or invasively, either by QCA or detection of percentage of stenosis, or by physiological assessment using FFR with a cutoff of less than 0.8 or IFR with a cutoff of less than 0.89 in major vessels, together with left ventricular ejection fraction less than 35%. And even with patients with multivessel disease, there is a trend now even to assess or identify lesions with significant hemodynamic significant decrease in FFR or IFR. In patients with new onset of heart failure or reduced left ventricular function, myocardial revascularization is recommended and class 1A recommendation when angina persists despite treatment with anti-anginal drugs. Just 2 weeks before, in the American Heart Association, the ischemia trial came to light, international study of comparative health effectiveness with medical invasive approaches. It included almost more than 5,000 patients that randomized into invasive arm and conservative arm. And I think in the next session there is a special lecture by Professor Magdi Abdelhamid about the ischemia, about the interpretation of ischemia trial among patients with stable ischemic heart disease and moderate to severe ischemia on non-invasive stress testing. Routine invasive therapy failed to reduce major adverse cardiac events compared with optimal medical treatment. The hard endpoints like cardiovascular mortality, resuscitated cardiac arrest, hospitalization by heart failure, by unstable angina. And there was also no benefit from invasive therapy regarding all-cause mortality or cardiovascular mortality and or MI. These results, be cautious, don't apply to patients with acute coronary syndrome, of course, highly symptomatic patients with high burden of anginal attacks. Left main stenosis have been excluded at the beginning of the study, or left ventricular ejection fraction less than 35%. Although the overall interpretation of this trial was negative, there were mixed findings with evidence for both harm and benefit. This signals that, number one, invasive therapy for stable ischemic heart disease patients needs to be carefully considered in the context of angina burden and background medical therapy. And we have to notice that in ischemia trial, there is a superior effect in the interventional arm or invasive arm regarding improvement of anginal attacks and improvement in the quality of life. The second point is the likelihood that optimal coronary revascularization can be achieved with low procedural complications. Ladies and gentlemen, my take-home message: the indications of revascularization in chronic coronary syndromes depend mainly on the presence or absence of symptoms and documentation of non-invasive ischemia. However, the individual risk-benefit ratio should always be evaluated and revascularization considered only if its expected benefit outweighs its potential risk. Also, the aspect of shared decision-making is a key, with full information given to the patient about the anticipated advantages and disadvantages of the two strategies, including even the depth-related bleeding risk on long-term basis in cases of revascularization by BCI. One of the most important additions in the recent guidelines, following recent data suggesting that FFR-guided PCI can lower the risk for acute MI compared to medical therapy in chronic coronary syndromes. Both anatomy and functional evaluation are to be considered. Either non-invasive or invasive functional evaluation is required for the assessment of myocardial ischemia associated with angiographic significant stenosis unless very high grade, more than 90% of diameter stenosis. And thank you for your attention.